As you may have just heard, our meeting is being recorded, and we do try to share the recordings with those who've registered. We have a great agenda today, and we're going to really talk about heat, bugs, and bites, and what every clinician should know going into the summer. Um, so we do offer CME for this session. The questions and the survey related to CME will be at the end of the slide deck and will also be placed in the chat. There's also QR code you can use, and we did check it this morning and it is working. So let us know if you are able, if you have any difficulties accessing that. Good news, none of our presenters on panel today have any conflicts of interest. And my hope is that at the end of this hour, you will really be more aware of all the resources and the risk factors related to summer health concerns, especially heat injuries, and understand how the rising temperatures are really having a significant seismic shift on our vector ecology, especially with ticks. And finally, we're going to explore another public health threat that surges in the summer, which is animal bites with a focus specifically on rabies. For those who do not know me, I am Aarti Barnes, the Chief Medical Officer at IDPH, and I will be followed by Sam Kerr, who is our Vector Control Program Manager, and we'll close it out with Dr. Austin, who is our Public Health Veterinarian and Deputy State Epidemiologist. So let's start up with some of our concerns around heat. Now, we think, why are we talking about heat illness in the Midwest? It's really a problem of the South, but it turns out that we really are in the Midwest exquisitely vulnerable to heat-related injuries during times of social vulnerability of a people who are socially vulnerable. So some of you may still remember the 1995 Chicago heat wave that really was devastating, caused hundreds of deaths. And most of the people were those who either could not afford electricity and air conditioning or could not afford to keep their windows open because they lived in high crime neighborhoods. And that vulnerability was also what came to pass with thousands of deaths during the Great Depression in 1936. And this was, a great, as I said, shot from the headline in 1936 about how it was devastating with thousands of people who died. So what does that mean for our future? What is waiting for us as far as heat-related injury? And this is what's projected for the Midwest. We can expect to see a lot more days above 95-degree weather. Why is that important? Because it's 95, above 95, we start seeing a lot more heat-related injury. ER visits go up. Also, our agricultural production goes down at that level. So lots of devastating implications. This projection also gives you what's going to happen, what's the energy demand. When you look at the cooling degree days, that's the energy demand for the Midwest. And this also involves, again, a risk of the energy or electricity that we will need to supply to keep our environments cool. And that's, if you look at that chart, it's red across the board for Illinois. And it tells you what we can expect for heavy precipitation. We are going to expect more floods. And with that comes a lot more health-related concerns from flooding and, of course, the nutrient pollution that we see. Again, if you have any questions, I've got to mention this before, try to use the Q&A and we'll try to answer them to the end, but we do have time spared for questions about anything we present today. So what I want you to take from this is this. If we as the public health and clinical community should brace ourselves for more extreme weather and heat-related injury events and understand who is at risk that we need to start thinking about, who's vulnerable that we need to start planning for, and how to do that planning and how to think about it. So I'll do a little bit of a deeper dive into that in a minute. So when you think about who's at risk, we think, of course, people who work outdoors are people with disabilities, vulnerable. We may not often think about also our pregnant people who are at risk, and just more hot days increases the risk of worsening birth outcomes and worsening pregnancy outcomes too. And this is important to also realize that it's not just about heat injury and heat illness per se. When you start having more hot days, you end up seeing worsening or more ER visits related to diabetes, related to kidney disease, related to just mental health conditions. And so when you think about to the right, you see a list of all the underlying conditions that's, you can get this information on CDC too, on what puts you at risk for heat injury. And how often do we ask our patients not just about whether they're unstably housed, which we have sometimes very traditional notions of what's quality housing that doesn't often really fit into the vulnerability to heat, but do they have access to cooling in their house? Are they socially isolated? And again, it's not just leaving the baby in the hot car, but it's really who also might be vulnerable to substances, struggling with substance use disorders. And how much time do they spend outdoor? How polluted is the environment? So when we break down some of those risk factors and we think about medications, sure, we're like, okay, you're on diuretics, you're going to be dehydrated. But how often do we think about people who are on antidepressants as being vulnerable? And you can see on the lower end of this chart, even being on SSRIs, SNRIs, tricyclics, those can really interfere with how your body regulates heat and put your patients at risk. So I think the question for you is, how often have you really done a sort of risk assessment, especially going into the summer, for your patients who might be at risk? And do you serve a community that is at risk? And so this is a great tool. This is called the Heat and Health Index, which is a national tool. It not just incorporates how hot it gets, but what drives people in this zip code to the ER. I mean, what are the community characteristics? And you can see the question is, do you service a community, especially if you are working in a safety net setting with people who have, either underlying chronic diseases or other social vulnerabilities that puts you at risk? You can see the top 10% of HHIs are scattered across the state in these zip codes. So be aware. And if you are servicing a community at risk, what do you need to be thinking about doing as far as planning? So one stage is look and see what's projected and educate your patients that, hey, this is a tool that they could use too. So this is on the CDC website. And I'm really hoping that the content of these websites, which is really rich at this moment, stays intact as we move forward. But right now, again, this is still great information. It not just tells you what's your heat risk, but I just ran this for Cook County yesterday for the zip code of my work, because I'm going to be at work today. But also, what do I do? What do I do if I'm outside? What do I do if I'm indoors? And so this tagging, this action plan to this information is very valuable. This takes you one step further and also gives you the air quality, which is a very important factor. Heat makes air quality worse, if you didn't know about that already. And as we're dealing with wildfires, as we're coming up on a pretty warm week and weekend, that can have significant impact. So even if your patients don't understand what's an AQI of over 100, or even you don't quite know what it is to translate to your patients, think about, here's a nice action plan that's right below it. It tells you, what do you do? This is today's air quality. This is for this zip code or this county. This is what you do. So I think this is a nice rubric for how to think about educating ourselves and our patients. And if you want to go one step further, I love the idea of focusing on indoor air quality. We did a lot about understanding that during our pandemic concentrations, but this really applies regardless. And this is a great interactive tool. The more you have time to explore this, the more comfortable you will get in having that conversations about how to educate your patients and talk to them about, air quality. There's also specific guidance for certain high-risk groups: children with asthma, pregnant people, and people with cardiovascular disease. So, go to the healthcare professional site and it'll give you more information. I'm going to give you a quick preview of what the information for pregnant people looks like. And this is great. It's a 5-step plan. It's interactive. There's a QR code. It tells, I don't know how many of you have used this for a pregnant for any of your pregnant patients, but it's a great tool as they are coming up into the summer. Stay cool, stay hydrated. And it's very specific what it means to stay cool, stay hydrated, check for heat-related symptoms, check air quality. Again, this is going to be an important thing in our considerations. Have a medication plan. So meds and air quality are things we don't often think about when we try to think about an action plan around heat injury. So this is a more generic one, same 5 principles, but easy to translate and hand out to your patients, especially if you don't have time to have a more involved conversation with them. And this is some questionnaire I think clinics could really think about using, especially if you service those high-risk communities with a high HHI. So what should your clinic do? We ask patients all kinds of questionnaires, PHQs, PHQ-9. What about asking about the chilled out question, especially if you flagged patients who are at risk for heat illness? And this really takes you through multiple components. One, I mean, ask about cooling, ask about housing. What are the questions within housing you need to ask for? So this is, again, a great questionnaire. Isolation, electricity, learning. Do they understand how to even interpret the weather information? If they don't, how can you help them with that? Drugs, what drugs are they on that makes them vulnerable, and how much time do they really spend outside? And often part of that 5-stage plan, especially for those who are vulnerable, includes a referral to LIHEAP. Now, in Illinois, LIHEAP, which is the Low Income Home Energy Assistance Program, is embedded within DECIO, our Department of Commerce. And so you may have referred your patients, especially if you work in safety net settings, you have to be within 150% of the federal poverty line to qualify for LIHEAP. To really say, how do you combat, what's the resources do they have? Now, as the proposed cuts are significant, I mean, LIHEAP across the nation has serviced like millions and millions of homes with people with disabilities, with someone with an older adult, a young child. The question is, what will come to bear for the clinical community if we no longer have this resource, if this funding cut goes through? And so be aware we might have to increase the number of local cooling centers if we don't have other ways of supporting families and people in our community that don't have access to great electricity and are at risk for outages. And this is just some of it, including Oasis that we have, but you can see there are large swaths that don't have easily accessible cooling centers in Illinois. When you do want to educate your patients about those symptoms, part of that 5-step plan, it's like also educating them on what to do in the event of a heat stroke. So it's a great graphic for heat stroke first aid. And again, remember, what parts do you need to cool down? The neck, under the arms, groin area. Make sure the legs are elevated. Spray them down with the cool water. Use a fan if you can. And so my charge to you is to really not wait and take this first step in trying to prepare your communities for upcoming heat events. We notify our patients when they're due for colonoscopies and all other preventative needs. There's no reason why we cannot really also do a risk assessment and notify our patients who are at risk. If your patients spend a lot of time out it takes them an hour waiting for a bus or waiting for a train, think about, are there systemic tools that we can think about who needs to really have a telemedicine appointment, especially during the hottest days? What procedures are really needed that would limit their mobility during this time? And how are we able to assess the risk and flag them to plan for heat? So get informed. The heat.gov is a great website. And again, I hope the content in these websites stays evidence-based and authentic and trusted as we move forward into preparing ourselves for what is to come. And think about one step further. We are starting to see, again, a lot of seismic shifts in the ecology, in our vector ecology. The warm days are completely energizing our bugs. It takes only really to be above 39 degrees Fahrenheit for a tick to start getting active. And what we're seeing with the deer tick, the black-legged tick is that it's expanding its territory by about 20 miles a year, northwards, westwards, in areas that it hasn't expanded before. And we're starting to identify new tick species too. So as we are going to expect to see more vector-borne disease, especially tick-borne disease, we are also starting to see threats we've never seen before. We need to brace ourselves for those and start becoming aware of what are the vector-borne diseases. So if as a clinician, if you never thought, oh, I don't need no vector-borne diseases, I never have to bother about them, well, that time is past. And I think we are going to be expected to be more familiar with what it looks like, how to think about it, how to diagnose it. And there's, again, a list of things that are going to be active threats to, especially in North America. So we did issue a health advisory last month about how to think through protecting yourself, your community, your patients from bites, especially tick bites and bug bites. And there are lots of resources, new resources that we put out, educational resources that Samkar is going to go into a deeper dive into in her presentation. That is great. Please, pay attention to that. The media is also a great source. This article just came out yesterday in the New York Times about there's a growing threat of ticks in our communities, in our environment, and what we can do to protect ourselves. So one thing to think, if you haven't been able to prevent the bite and now you're at the stage of after the bite, think about which of your patients really need prophylaxis and how do you think about it. There's a great algorithm. At this point, maybe the first map is not so current because everyone, pretty much a lot of the US is going to start seeing more and more Lyme. But was this tick really removed within 72 hours? Prophylaxis is not effective past 72 hours. Was it engorged with blood? Was it really a black-legged tick? And if the answer is no, the answer is no, no prophylaxis needed. And is doxycycline safe? And it's really a one-time dose of doxycycline. So if you are able to effectively make a determination that someone needs prophylaxis, again, all these links are live. And when we send out the presentation, you will be able to get access to these live links, which have all these resources. It's pretty effective. The one that scares me a lot is Rocky Mountain spot fever. We don't have prophylaxis for that. In general, vaccines for vector-borne diseases for humans is very limited. We've had some local transmission of dengue in Florida, but it's still not recommended for dengue in say Florida state. More, I think they recently increased the recommendation just for kids in Puerto Rico, and they're seeing a lot more endemic transmission there. So post-exposure or PEP for tularemia has also been very limited setting. So I think the more important thing is remember primary prevention, preventing the actual bite is going to be where we have to focus our energies in. And just one thing to flag, as we are starting to see for the first time in a couple of decades, local transmission of malaria in a couple of the southern states, we don't do a great job as clinicians in really educating our patients about malaria pre-exposure prophylaxis before travel. A bulk of our malaria is still imported, and I just want to flag malaria pre-exposure prophylaxis is very effective. If we have, please make sure to have an educated conversation with your patients before they travel, as the world is getting smaller and travel is becoming more common. And so a key thing we don't do a great job also is reporting. And why we rely, you think, oh, the lab will just report the positive results. A lot of diagnosis really hinges on just the clinical, not just lab criteria. And so it's important for providers. You have 3 days. I've just highlighted a few of the vector-borne diseases that are reportable in Illinois. So get familiar with what's reportable, and please start reporting to us, to your local health department when you do have cases of these. We want to get a better estimate of what the trends are going to be for these diseases in our communities, in our environment, as we start expecting more of vector-borne diseases. And I'm going to end with this. I think some of you may have heard of alpha-gal, others not. Alpha-gal is an unfortunate I would say, collateral damage from a lot of the tick activity that we're seeing. It's a pretty serious red meat allergy that can happen after a tick bite. Now, and alpha-gal is a molecule that's really found on most mammals. So if you consume a red meat or mammalian products, including like stuff made of lard, even if you're not really necessarily eating the red meat, you could have a pretty significant serious allergic reaction to it. Mostly, it hinges on the Lone Star tick, but it's not necessarily just the Lone Star tick that can cause this. And providers need to know how to diagnose it. You do have to do you could do a blood test, an IgE to alpha-gal, or skin allergy testing. But more important, I think it's going to be important to start documenting. There is a dedicated ICD code for this, and it's going to be important to start documenting it, because while this is not reportable locally or nationally, we do want to get a sense about whether this is starting to be a burgeoning problem that we need to think about public health resources for. And importantly, I think even as a clinic, it'll be good for you to see if this is the population you serve that's starting to have more of this condition. So please, start documenting accurately for alpha-gal if you are starting to see this. And with that, I'm going to turn it over to Sam Kerr, who'll take you through our vector-borne surveillance and control program. Thank you.
Hi, everyone. My name is Samantha Kerr. I'm the Vector Surveillance and Control Program Manager at the Illinois Department of Public Health. And today I'm going to give you some information about different vector-borne diseases that we are monitoring in Illinois, where you can go to find all of this information to stay up to date with the most accurate information, and then provide information on where to find some of these educational materials we have recently developed. So first, I just wanted to start with what do we actually do in our vector surveillance and control program. And we do a little bit of everything here and there, but today I'm going to focus on tick and mosquitoes. We provide grants to our certified local health departments to actually go out and collect mosquitoes through trapping. They grind them up and then they test them for West Nile virus. And then we collect all of that data and have it out there for the public on our mapping website, which I'll show in a moment. We also have an active tick surveillance grant where we give money to local health departments to go out in the environment, collect ticks. They send those ticks to us at IDPH, where we identify them and we sort them and we test them for pathogens of public health importance. So I will show you where to find all of this information on our website. We also take a lot of time communicating results to our partners, local health departments, universities, and the public, and then provide education on prevention and just awareness. So first, I'll talk about West Nile virus very briefly. Right now, I know the slide says we have 16 positive counties. Another county popped up positive this morning, so we have 17 positive counties. Christian County popped up positive. But here, this is the link to our West Nile virus surveillance website, where you can find summary information about the West Nile virus positives throughout the state. You can click on your county specifically, and it will populate the county and all of the zip codes where a positive either mosquito, horse, or other mammal or bird has tested positive for West Nile. And there's also information on there about human West Nile virus cases by county. Fortunately, right now, all of our positives have been from mosquito pools, and we do not have any human cases yet. But this is our #1 mosquito-borne vector-borne disease here in Illinois. The next thing I would like to walk you through is our new Illinois tick-borne disease dashboard. This can be found here at the link dph.illinois.gov/ticks. When you go to this link, our dashboard is located on the lower left-hand side of the web page under tick surveillance map. So this is an example of what the dashboard looks like when you first open it. It is broken out into tick-borne diseases, Lyme disease, spotted fever group, rickettsiosis, ehrlichiosis, anaplasmosis, babesiosis, hard tick relapsing fever, also known as Borrelia miyamotoi disease, Heartland virus. We have information on alpha-gal syndrome, and we have distribution for the longhorn tick as well. So once you are on this page, you will click on the button of the disease that you are interested in. And once you select a button, you will get this web page that will pop up. You'll have 3 different options once you select a disease. For this example, I chose Lyme disease. So your first option is an overview of Lyme disease. Then we have 2 dashboards of surveillance information of Lyme disease in tick populations and Lyme disease in humans. So when you select the Lyme disease overview, you come to this page where it gives background information, distribution on the black-legged tick throughout the United States. It provides information on the different habitats where you can find the black-legged tick in those forested leaf litter areas. It will provide information on incubation period and symptoms for Lyme disease. And as you keep scrolling down, it provides information on treatment and resources that you can click on and download. Different examples of the EM rash, resources in English, Spanish, etc. So as we go back to that option page on our dashboard, if we go to Lyme disease and ticks, once you select that, you will go, this page will open, and you can select a county that you are interested in learning statistics about. So here on the map in the middle, the key is on the left-hand side, top left-hand side. So this is showing if counties have detected Lyme disease in their tick populations. So those counties that are shaded in the dark blue have had ticks collected from the environment that have tested positive for Lyme disease. That lighter blue, ticks have been collected but tested negative for Lyme disease, and then the white counties, the counties have not been sampled yet. So we have some summary information here. In this example, I chose Putnam County. In the left, or the bottom left-hand side, we have that tick population is established in that county. Lyme disease in ticks has been detected. We have tested 56 ticks and 33 have been positive. Transitioning over to the right-hand side of the dashboard, we have a pie chart. This breaks up the ticks into adults and nymphs and positives and negatives here. So you can see that we've had 5 positive adults and 28 positive nymphs from Putnam County specifically. And then as you move down to the bottom right-hand side, it shows our black-legged tick collections by month. So we can see with the dark blue, this is our adult tick populations when they are most active, when we have gone and collected them. Our nymph populations is that medium blue there, where you can see that they're primarily active May through the end of June. And then our larvae active in the summer months. So we have, you can click on each county and the information will change depending on that county. So as you can see, we have Lyme disease and ticks spanning all throughout Illinois, even into southern Illinois. So we're hoping to dispel the rumor that you have to travel to Wisconsin to get Lyme disease. You can definitely get it here in Illinois. And then our third selection is Lyme disease in humans dashboard. So I will walk through that. So for this example, in the middle, we have our map. It shows our 3-year average human incidence rate of Lyme disease in humans. For this example, I chose Joe Davies County. Those counties that are in dark blue have a higher incidence of above 10, and it tapers down as the shades lighten. So we'll start at the top left of the dashboard again. I'll walk through this. So this line graph is showing the total Illinois Lyme disease cases by year. So this is the total for all of Illinois. And then underneath it is specific to the county that you select. So for example, in 2023, Joe Daviess County had 9 confirmed or probable cases of human Lyme disease, and comparing to the total for Illinois, which is just under 400 cases. So 9 of those were from Joe Daviess County. As we transition over to the right-hand side of the dashboard, we get more information. We have that the black-legged tick population status is established in Joe Daviess County. The ticks have tested positive. We've had a total of 34 cases between 2021 and 2023, which is the numbers we use to calculate the human incidence rate. And then our specific human incidence rate for Joe Daviess County is 51.43, which is high incidence. So you can go through this and select whatever county you would like, and that information will populate. And then just briefly, I want to touch base on a couple of our new educational materials that we have for download on our website. These are all located on our dph.illinois.gov/ticks. If you scroll to the bottom or click on publications, they're all listed down there. Feel free to download and distribute how you see fit. We have a notification of field trip and a notification to parent guardian of tick found on student. These are kind of geared more towards school settings, but we do have them available. There's information on how to monitor for symptoms of tick-borne disease, how to reduce your chances of a tick bite, and what to do if you are bitten. So the best way to remove is to grasp the tick as close to the skin as possible with fine tip tweezers and pull straight up. We suggest keeping the tick by putting it in a little baggie, like a Ziploc baggie, and throwing it in your freezer. If you develop any types of symptoms of potential tick-borne disease, you can then identify that tick to species, and that will help. We don't suggest testing the individual ticks for disease themselves because we don't know how long that tick has been attached. If it's only been attached for a few hours, it has not had the time to transmit that disease to you. Then again, if you find one tick and then there may be another one, you know, in the hairline or something that you've missed that may test positive, where the one you've removed and sent in for testing could test negative. So we really tell people to rely on any symptomology they might have after a tick bite, and telling their clinician that they did have a tick bite and where they were when they experienced that tick bite, if they know where they were. We also have a camper checklist, so things to think about before you go to camp, like packing an insect repellent, DEET, picaridin, IR 3535. You can prepare your clothing and your gear with permethrin, which you can apply not to the skin, but to your gear, and then let it dry overnight. And then you can wear it or use it the next day. And then to pack a tick removal tool. So just keep a pair of tweezers with you. At camp, just remembering to use a repellent, check for ticks, and then remove any ticks that you can find promptly. And then after camp, placing all of your clothes and gear in the dryer. A lot of people think putting clothes in the washer will kill a tick. The washing machine will, in fact, not kill ticks. The dryer is what kills the ticks. So you want to dry your clothing or gear on high heat for at least 10 minutes, and that will take all the humidity out of the environment, and the ticks will desiccate. They will die, but they will not die in the washing machine. This is a nice little tick bite what to do on proper tick removal and symptomology to watch for tick-borne diseases. And then just briefly, we have a couple new educational materials as well. We've developed an Illinois ABCs of Tick-Borne Disease, 2 different versions of this book. There is a preschool through grade 2, and then there is a grade 3 through grade 6. So the content is, the messaging is the same, but the content is different depending on the grade level of the children. So here's an example of what this one looks like with a counting activity. And then here's an example of our grade 3 through grade 6. E is for environment with different information on tick environment, and then an activity associated with it. So we have both of these books on our website for download. We have a color version and a black and white version as well. And then finally, we also have an Illinois Tick Detectives workbook, whereas the ABCs were kind of geared for younger children. This book is geared for more older kids, so grade 7 and up, and all the way through adults. It has more comprehensive information in it about applying insect repellents and staying safe in the middle of trails, tick checks, everything like that. So that is also available on our website for download and distribution. And with that, I will turn it back over to Dr. Barnes. Thank you very much for having me here today.
Thank you. And Dr. Austin, I'm going to just start sharing your
Okay, while she's getting going, I just wanted to mention a few things, and don't forget your pets can also get tick-borne diseases, so make sure you protect them, and they can also be exposed to some of these animals I'm going to talk about with rabies as well. So don't forget your pets at the same time. So what I'm going to talk about today is I'm going to give a quick review about animal bites and rabies in Illinois. And this is really the time of the year when we get all the questions about bats and exposures. The bats have been hibernating in the winter, and now they're awakening and they're starting to cause a lot of different exposures. So what we'll be discussing today, and also just trying to make sure that we know which animals are high risk and which ones are not. Next. So this is what we're going to cover, and I also wanted to mention rabies post-exposure prophylaxis, or PEP. This is what you give to people if they've been exposed to a high-risk animal to prevent them from developing rabies. So we'll talk some about that as well. Next. So let's talk about the groups of animals and whether they're low or high risk for rabies in Illinois. So low risk species are small rodents like rats, mice, squirrels, rabbits, pocket pets like the gerbils and hamsters, dogs, cats, ferrets, and livestock. These are very low risk animals in Illinois, so it's very unlikely you would need to give rabies PEP for these species. And the important information for dogs and cats is whether the bite was expected or provoked. So you have to pretend you're a dog and think about whether what somebody is doing is irritating. So like if somebody, a total stranger, comes up to you and tries to pet you, if they try to take your food away, if they're running or doing any kind of skateboarding or anything that's going right by a dog really fast, that stimulates their chase instinct, and they may chase and then nip. Also, do they have any kind of neurologic signs? That would be a sign that could be rabies. Was the animal rabies vaccinated? So dogs and cats should be vaccinated for rabies in Illinois if they're owned. And then also, can the animal be held for 10 days after the bite? So if we can watch them for 10 days and they survive, that's a very good clue that they absolutely did not have rabies. And then if necessary, so we do have some situations where, say, a cat or dog is neurologic. It could be in a vet clinic or something like that where it bites a tick. If they're neurologic, it could be rabies. We can actually test those animals for rabies. And if they're negative, no need for rabies PEP. Also, a very good thing that is available on our website is a map of the last rabid dog or cat by county. We have a lot of people who are very anxious about bites. And typically, if you look on that site, from the 1960s to the 1980s, we had some dog and cats positive for rabies, but typically after that, we have not. We've only had 2 cats in more recent times that have been rabid. So it's very unlikely in Illinois that you're going to find a dog or cat that it is rabid. The highest risk species, so if you hear somebody say they were exposed to a bat, you really need to perk up your ears and pay attention. The highest risk species is the bat, and especially from June to September is when we see them getting into people's homes and people getting exposed. So other high risk species are raccoons, skunk, fox, and coyotes. So even though these have not been positive for a while in the state, we don't have many of these species tested, so there could be pockets of rabies in the state. Next slide. So why is it so important to correctly assess the exposure? Rabies treatment is extremely expensive. It's overutilized and results in a financial burden on the healthcare system or the patient. Some people have reported that the first day of treatment for rabies was $20,000. We had someone at our health department who had to have rabies PEP, and the cost was actually higher than the delivery cost for her baby born in the hospital. So we really want to make sure that we give it when it's needed, but not when it's not. And rabies PEP consists of immune globulin and vaccine on day 0, and then 3 more doses of vaccine on days 3, 7, and 14. And this is usually all done in an ED or infusion unit. So if someone does not have health insurance or has a high deductible, very expensive. So we want to give it when we need to, but not when we don't. And it would really be good if hospital systems can figure out if you can do vaccine doses 2 through 4 at a nearby urgent or prompt care rather than in a hospital setting. Next. So we're going to go over much more about bats because they are the most common species to actually be something we worry about with rabies. We've had 13 rabid bats so far this year. And most people do not have a fondness for bats, especially not in their homes. But in Illinois, the main bat species that is tested for rabies is the big brown bat. But if you look in the upper left corner, that's a skull of a bat. You can tell they are not big. They're very tiny. And you can also see that they're colonial. So in the upper right of the slide, you can see they're all smashed together. These are a colony of bats that are often can be in people's attics or basements. So they're not single in a house. There's typically a whole colony of them. And typically 3 to 7% of bats tested in the state will be rabies positive. And also just keep in mind that they can be in any kind of man-made structures. Could be schools, could be churches, it can be all kinds of settings that they love to be inside with you. We had somebody recently who had a bat in the home. They decided they would nurse it back to health, and they were feeding it apples. They're insectivorous, so it wouldn't have helped anyway, but then ended up testing positive for rabies. So we do have people who are feeling very generous and want to save the animal and then expose themselves. Next slide. So bats in bad places. Bats can, again, be in a variety of indoor settings, daycare, schools, etc. We've even had one in an ICU at a hospital that was under construction, another one in a long-term care facility, and at least in the school incident to the left, only the teacher was exposed. That's what kind of bothered me about that one. It's like, oh, we didn't let the children touch the bat, but the teacher did. And these situations are especially critical to resolve, as there could be a bat colony or it could be an individual animal that entered through a construction site or open door. And many people could be exposed. I mean, my worst nightmare is a Girl Scout camp where they're all in one room together and there's bats in the room while they're sleeping. So the most important thing to do is not to tell people to let the bat go outside, but get it captured safely. With the most recent long-term care situation we had, an employee let the bat go outside and then it could not be tested for rabies. Next. So bat exposures I want to mention are a bit different than other exposures. Really, with most high-risk species, we're worried about bites from that animal. With bats, if they're positive or there's no testing that can be conducted, exposures consist of bites. If you wake up in the room to a bat in the room, you could have been bitten while you're sleeping in that room, then that is going to need rabies treatment if you can't test that bat. If you have physical contact with a bat, such as you stick a bare foot into a shoe and there's actually a bat in the shoe, if a flying animal at night hits you in the face and you don't know what part of the bat hit you, or if you have a person alone in the room who cannot say whether they were bitten. So like an infant, small child, someone with dementia, someone who's intoxicated or high and just doesn't know what their interaction was. We also get a lot of people who are very anxious about bats or rabies, and they can find a mark on their body. They may never have even seen a bat, but they are going to say, hey, come in to you and say, hey, I think I have a bat bite, look at this mark. But a mark alone is certainly not enough to say it was a bat bite. We all have marks on our skin sometimes when we have cuts or scrapes. But the most important thing to do, again, if I can't mention it as many times as I can, is make sure that the bat gets in for testing. So the person can call animal control so they can come pick up the bat, euthanize it, and get it tested at our lab. But another thing to keep in mind is that you have to if you have one bat in your home, it's very possible that if you didn't leave a window open or a door open, that there is a whole colony in your house somewhere. So in that case, you need to get a wildlife professional to come in and get them out of your house. In the winter, they hibernate, but you can only exclude them from the home in the spring and the fall, not in the summer. So in the summer, you just have to make sure they don't get into the living areas of the home. And this is because that's the time of the year when they're having babies. And if you shut them off from the outside, they'll all die and smell up the house, and it's a bad situation. And also with bat exposures, don't forget if you have bats in your home, their pets may have been exposed as well. Next slide. So this slide shows, the chart shows the correctness of the recommendations for rabies PEP by 3 species. So blue is bat, yellow is dog, and the gray is cats. So it's often given, we often give it when it's not needed. So in blue, 58% of the time with bats, we don't need to give it, and we did. 24% for dogs, we give it and it's not correct. And then 9% of the time in cats. So especially, there's a lot of over administration of rabies PEP, especially in the dogs and cats. Next. So there are millions of bites, thousands of ED visits, and what do we really need to do? So in Illinois, rabies exposures are reportable. We have over 2,500 reported each year. And what do the patients really need? Wound care. Somebody will tell me, oh, I had a bite from a cat. I'm typically not worried about rabies. I'm worried about the horrible Pasteurella infection they could get. They have needle teeth that inject deeply into tissue, and they often have Pasteurella, and that's going to be something very significant for that person. So antibiotic therapy may be necessary, tetanus booster, and also the most important thing is a good rabies-specific risk assessment. And if you need to, consult with your local health department. They're very good at these. And if they don't know, they give me a call. Next. And don't always rush in and say you need to have rabies PEP. Sometimes you're going to have to talk to the person because they get online and they think they're going to die, and you're going to have to talk to them about what their exposure was. So it's medically urgent, but not an emergency to start rabies PEP. The rabies virus has to multiply at the site of the bite for a while before it gets into nerve tissue where it can't be handled by PEP. So start treatment within a few days if there is a exposure that is a rabies exposure. So if it's a high-risk animal and it's available for testing, get it in for testing. The turnaround time is very quick at our lab. If it gets in before 11 a.m., the test result is available that day. If it gets in after 11 a.m., it's available the next day. So please don't, say, oh, I'll start them on rabies PEP now, and, we'll wait for the bat result later. That, go ahead and wait for that result before you start rabies PEP if it's been within a few days. The rabies ACIP can be used for assessments, but knowing the status of animal rabies in an area is very important for decision making. A dog bite in Illinois is vastly different from a dog bite in India, so you do have to know where you are and where the exposure occurred. And also, rabies PEP is often given incorrectly. About 51% of the time in Illinois, it's given incorrectly. So it's a very complicated schedule. You have to know the location to give the vaccine and the rig, and you never give rig and vaccine together in the same location at the same time, because then you just have to give extra vaccines. So make sure, if you're not familiar with how to give it, make sure you go to the CDC website. They have great information about the proper way to give rabies PEP, so you don't have to give more vaccines, which will just result in more expense. Next. So what can we do about the issue of rabies PEP expense? So I start to try, or just about the fact that, we want to reduce the number of people who are exposed. So we want to start trying to put out prevention measures in June about bat exposures, keeping bats out of the home, calling animal control or public health if there's a bat in the home that needs to be collected for testing. And small local health departments need to emphasize to their county board that animal control should indeed pick up bats for testing. Sometimes they will only do dogs and cats. And then do not smash the bat head. There's a surprising number of people that have baseball bats or tennis rackets near their bed, and they will pick them up and smash the bat in the head, and then we can't test it. So we want to make sure that they look online. There's some great videos on the way to safely capture a bat. They can also call animal control to come do it. You just don't want to lose it between when you've seen it and when animal control comes. So they can go look at those videos and then catch it themselves safely or call animal control. And then we want to have correct administration for rabies PEP so that we don't have people having to get extra doses and have to return to an ED. And then reducing unnecessary rabies PEP, which is really probably the most important thing. Again, dogs and cats, it has to be something pretty dramatic for me to say that a dog or cat bite needs rabies PEP. They got to be neurologic. They got to be over the top aggressive, just something that really makes you think this could be rabies, not just a dog that's a bad behavior. And feel free to call the local health department for advice. As I mentioned, they're very helpful in these situations. They can help with trying to get the bat in for testing. They can help give advice about it. And if, like I said, if it's something complicated and kind of nuanced, they can call me and I'll help them, come up with whether rabies PEP is really needed or not. And next slide. I'll be glad to answer any questions as we get them in the chat. So thank you very much.
Great, thank you, Dr. Austin. And as we start winding down, I think just wanting to flag everyone that we have the next thing in July, before we head to back to school, it's what's going on with our children's health agenda in Illinois. What are the things we're focusing on, and what we need to know before the back to school period. And finally, in August, we're going to do talk about our cancer prevention work in Illinois. So stay tuned. And if any of those are of interest to you, please don't forget to register. Reach out if you have specific questions for the medical advisor team. We also have a QR code and a way to reach out to us directly for this is specific for clinicians if they have clinician related clinical questions. But all our advisories are on Siren. Please do not forget to sign up for our Siren. You can use this QR code for our Siren to sign up if you want to get tapped into our health advisories. And finally, this is the QR code for the CME. We will send out these slides, and we keep the CME link live for a week. So please, I'll hover on this for a minute if people want to take a chance. And let's see if we can paste. Oh yes, David pasted the a link to the forms in the chat too. And so you could access it through there. All right. And with that, I will stop sharing and open it up for any questions from our team, our people who are attending today.
Yeah, I think question about whether you ask a person to try to collect the bat themselves or get someone in. Part of the problem is some people will shut the door and then call animal control, and animal control shows up 4 or 5 hours later and the bat has disappeared from the room. So you kind of have to know the person to see if they're calm enough to be able to safely, put a plastic container over the bat, something like that. But you really don't want to lose it, in the house. You really want to make sure that you have it. So some of that is assessing that person and whether they're capable of doing that. Some of them have already been exposed. So if they wake up to a bat in the room, they're already exposed, right? So they're going to need rabies PEP unless it tests negative. So kind of evaluating the situation and that person about whether they're capable of doing that is important.
Great. And Dr. Austin, we have one more question in the chat. CDC says you have 14 days before starting PEP. What is the recommendation for IDPH?
No, you don't have 14 days. You have a couple days. So I think there's different time periods. So you have to be careful what you're looking at. That's probably, the earliest incubation period is 2 weeks. But everything I have read is you have 2 to 3 days after an exposure to start rabies PEP. Like I said, the rabies virus does multiply at the site of the bite for a while before it gets into nerve tissue and where you can't reach it with rabies PEP. So you do have a couple days, but I would certainly never wait, something like 2 weeks or something. Now, on the other hand, let's say somebody just tells you about this exposure and it happened 2 weeks ago, you still need to go ahead and give rabies PEP. It's never too late to give it. So it can possibly help. So you want to make sure you give it if you are notified pretty late about it. But if you know right today that somebody was exposed yesterday, you want to make sure they start it within 2 to 3 days.
Okay, great. Let's see. With the concerning dog bite, you can't wait for PEP 10 days while the dog is isolated, right?
Yeah, so concerning dog bite again is it should be pretty limited in Illinois, but you know, if you did have some dog that was neurologic, there's a lot of I think we all know, we've all probably met an aggressive dog that has nothing to do with rabies. They're just, unfortunately, that's their temperament. But if you do have an extreme, you know, a dog with neurologic signs or a cat with neurologic signs and they're bitten, no, you shouldn't wait the 10 days. Though, what you could do is go ahead and test it, euthanize and test it. You can't test for rabies without euthanasia and testing the brain. So yeah, you would never wait 10 days if you actually thought that dog or cat had it. But if you're have somebody who's very worried, you can say, oh, you know, the dog's going to be watched for 10 days. We're going to watch it to make sure it doesn't develop any signs during the 10 days. And that can, you know, provide a measure of reassurance for them.
Any other questions? Please place it in the Q&A, or at this point, if anyone wishes to raise their hand, we can. You can also we can see if we can come off mute and help answer. See, I don't see any hands raised. We'll give it one more minute. And again, just want to say thank you again for attending our session today. We need to get our slides approved through an internal process before we send it out. So sometimes it can take a few days before you are able to get the full version. Someone wants a link to the CME. I'll share my screen again. That's the QR code. There's also the link in the chat, so you can scroll up in the chat and see the link for the CME form. All right, since I'm on, I'm sharing my screen, I cannot see if there are any other questions in the chat. I don't know, Sam or Dr. Austin, are you able to see if there are any additional questions?
No, looks like that's all.
Okay. All right. So in that case, we'll give everyone a few minutes of their time back. Thank you all for attending. And again, reach out to us if you have any questions about any of the information we shared today. All right. Take care.